So, I'm going to suggest we get started. Hello, everyone. Thank you. Welcome. Thank you for coming out, especially on our first really slippery night of the year. So, my name is Alex, and I help to organize this panel, which is sponsored by a few local civic groups, by a group called Helena Rising, Our Revolution Helena, the Montana Human Rights Network, and the Lewis and Clark County Democrats. Our goal tonight is to learn about two things from a set of experts. The first thing is how Medicaid expansion has already affected Montana since that came into force. And the second thing is to talk about what's at stake with the ballot initiative I-185, which would provide funding to continue Medicaid expansion by taxing tobacco products. So I want to make sure that I'm clear that this is not meant to be a partisan event. We did not set this up as an opportunity for people to say, oh, you have to do this or you have to do that. I suspect some of the panelists have opinions, and we look forward to hearing from them, but we didn't set it up to advocate one way or the other. So now let me introduce the speakers. I'll start off with Christina Go in the middle, who is an attorney with extensive experience in health insurance and healthcare law. She was born in Billings, Montana. She has a BA in history from Stanford University and a JD from Santa Clara University Law School. She is a member of the Bar of California, 1982 inactive, it said. And Montana, 1995 to ever. Ms. Go worked as a staff attorney, chief legal counsel, and general counsel for the Montana Department of Securities and Insurance from 1999 through 2016. She worked in all areas of insurance regulation. Beginning in 2010, she worked exclusively on implementing state and federal health insurance laws and healthcare delivery reform. In 2017, Ms. Go established a solo law practice focusing on state and federal health law issues, healthcare law issues. Okay, so that's the first person I have. The second is Kim Abbott, the far end from me, who is a member of the Montana House of Representatives, where she currently represents District 83, which covers, chances are, quite a few of us. A big chunk of Helena and out into the valley over that way a little bit. She has been an advocate for Medicaid expansion in the past. She got into the state legislature just too late for vote for it last time, but I'm sure she'll get to do lots of voting this coming, well, with luck, see how things go in November. If she gets re-elected, she'll get to do lots of voting. She did help to draft I-185, which is the initiative that would provide funding for continued Medicaid expansion. And in her spare time, or something like that, she's also co-director of the Montana Human Rights Network here in Helena. Good, thank you. And then the final person is Jill-Marie Steeley, who's the executive director of the Pureview Health Center. So she has experience with how healthcare providers see Medicaid expansion in Montana. Jill joined Pureview Health Center in 2015. Prior to joining the organization, she spent nearly 4 years as the Director of Health and Human Services in Gallatin County Health Department, 7.5 years as the Director and Founding Director, it sounds like, of the Madison County Health Department, and was a Senior Analyst for Goldman Sachs in Salt Lake City, Utah for 4 years before that. Jill has a master's degree in public health from the University of Montana and a Bachelor of Science degree in business administration from the University of Phoenix. Jill is excited to be part of a team of professionals who thoroughly enjoy working with the patients we serve, she serves, they serve, and works tirelessly to improve the health of Lewis and Clark County residents. So, thank you. That is our very, very expert panel, and my proposal now is to get out of their way. And I'm going to take notes to make sure this gets written up, but I'll let them do the talking. Thank you, everyone.
Thanks. Thank you.
Yay.
So I'm going to go first and just give a little background and history, because my expertise is really more health insurance and health coverage and less Medicaid, but a little bit of everything. And then Jill is going to talk about the perspective from a healthcare provider perspective at the Pureview Health Center. And then Kim gets to talk about the ballot initiative and what's going on with that. So I coordinated several studies beginning in 2014 on the insured population or the coverage rates in Montana. I did this as part of my role at the insurance department. But prior to that, we actually had commissioned a survey, actually household survey, done by the University of Montana to try to pin down the uninsured rate prior to 2014. So it was done in 2012, prior to a lot of the changes that were supposed to occur under the Affordable Care Act. So at that time, it was determined that the uninsured rate was around 20%. It had been in that range, often estimated to be up to 22% for, I think, decades. There's always been a large uninsured population in the state of Montana. So from the point, 2014, was when the exchange opened and when a lot of the changes that occurred in the individual market, like guaranteed issue, community rating, the premium tax credits, all of that occurred, but Montana had not expanded Medicaid yet. So that was just individual market. So we began to track the uninsured rate and did see it fall year after year. And on that report that you have, there is a little graph. I did updated coverage report in 2018 that was funded by the Montana Healthcare Foundation. So at that time, we did a survey of the insurers and found out how many people they were covering. And then we also looked at the Medicaid numbers, the Medicare numbers, and the employer group health insurance numbers, which are harder to pin down. But you saw the rates fall from the time the exchange opened in 2014 to 17%, and then we got to about 15% in 2015. And then when Medicaid was expanded in 2016, the uninsured rate dropped to 7.4. And we hadn't measured it since then. So the 2018 study was the first time that that had been done again. And what we found is that Medicaid had continued to grow. And those numbers are also on the sheet. There's a graph on the back. At the time this was done, which was about January of 2018, the Medicaid numbers are actually from November of 2017. You know, Medicaid was up to about almost 250,000. And as you know, Medicaid expansion is covering about 100,000 people. It is growing to that amount. So these numbers are even bigger at this point in time. The individual market at that time had shrunk from what it was in 2014. It has declined between 16 and 18, the individual market declined about 22%. And I'm not going to talk about that very much here. I mean, there was some migration from the individual market to Medicaid expansion, but that's not the only reason. A lot of it had to do with premium increases and things like that that happened in the individual market. So for people that do not receive significant premium subsidies, the individual market has become fairly unaffordable. And I am working on some other projects through a contract with the Montana Healthcare Foundation to try to stabilize the individual market and bring rates down, but again, not tonight's topic, so I won't talk about that either. What we did notice was, even though the individual market has declined, the uninsured rate, unfortunately, did not go up by much. It was statistically insignificant. It's, you know, we now have, but we still have 83,000 approximately uninsured people in the state, which is a lot. I mean, it's at about 7.8. But give or take. So, but what the state has is a large percentage of the population covered by Medicaid and Medicare, because we have one of the oldest populations in the United States, really sitting at about 5th, grouped with a bunch of other states, but we're definitely in the top 10 and really close to that number 5 spot. So
More than
we have
Florida. More than Florida.
I don't know about more than Florida, but, pretty high up there. So we have maybe as much as 44% of the population is covered by Medicaid and Medicare, and I don't really see that changing at this point in time. And then, almost half of the population is covered by employer group. So that's sort of the background, and you feel free to ask questions. You should know that of the Medicaid population, approximately half of those, of the total, are children. So we really are covering a lot of kids. And that total number there is obviously not just Medicaid expansion, but also what they call the dual eligibles, which are Medicaid and Medicare. There's the elderly that are also low income, and people that were covered anyway because they're low income families with children under the age of 18. So nationally, the premiums in the individual market have gone up by about 25%, and there's a lot of reasons for that, and also contributed to that decrease in the individual market. So, I'm not talking about reinsurance. Okay. As part of some other studies that we did about the individual market in reinsurance, the Healthcare Foundation also funded a study, an actuarial study, about the impact of Medicaid expansion on individual market premiums. And there have been studies, even the federal government did some studies about that. And what they show, and what Wakely's conclusions were as well, is that if Medicaid expansion ends, the individual market will see additional rate increases over and above what would have already happened. Those rate increases could range from 4 to 7%. I think 4 is probably a low estimate, but they don't know. This has to do with, there's a higher morbidity of people who are in that income range when they come into the individual market. And remember that the only people in that population who could be covered in the individual market are people between 100 and 138. Because I think some people may have forgotten about the Medicaid, maybe not people here tonight, but about the Medicaid gap, and which is what we saw a lot when we were doing enrollment campaigns pre-2016, is that there was a lot of people out there who were under 100% and unable to get any kind of coverage at all, weren't eligible for anything. So, but the people between 100 and 138% who do enroll in a subsidized individual market tend to have higher morbidity and therefore higher risk. And so we did see some premium increases that could have decreases that could have been attributed to that when Medicaid was expanded. And I think the federal government did a study that said that states that did not expand Medicaid had individual market rates that were 7 to 11% higher than other states. So we would, so approximately maybe 6,500 to 12,000 people, previously Medicaid eligible people, might migrate into the individual market in 2020 is what their estimate was. That's less than those that would be eligible because they won't all sign up for the individual market. And then the number of uninsured will increase significantly, obviously. And the uninsured rate most likely would go down. I mean, it's impossible to predict, but if you lose coverage for 100,000 people in a state of 1 million, you're going to see the uninsured rates rise to at least probably 16, 17%, if not more. It's hard to predict because no state has ever done this before. Montana would be the first to expand Medicaid and then rescind it. Currently, there are 34 states that have expanded Medicaid and 3 that are considering Medicaid expansions, which could possibly bring the number up to 37. So, we would definitely be back in the minority on that. The other thing about shifting the population that's in Medicaid to individual coverage, not that many of them would be eligible, but the ones who would, the coverage is not identical. I mean, the same benefits are there, but the cost sharing structure is different and in the end higher, because even though the health program in Montana is a waiver program, so people do pay some premium depending on their income, and they do pay some cost sharing in the terms of co-payments or co-insurance. Their total investment, which includes premium, is capped at 5%. And although there are cost sharing reductions for individuals who sign up for individual coverage in that income range, the cap doesn't include premium. So they pay 2+% of their income in premium, and then they pay another chunk of money in maximum out of pocket in co-insurance and co-payments. So it doesn't work as well. I would also just say, I mean, not that it's hasn't helped a lot of people along the way, but the complexities of private health insurance plans do make them more difficult to use for some people, particularly in rural areas because of the network component. If you go out of network and you have an individual market plan, or an employee group plan for that matter, you basically lose most of your benefits. The maximum out-of-pocket protections are no longer there. They're just gone. And the other thing I wanted to remind people of historically is that even though obviously this costs the state some money, as is demonstrated by the ballot initiative, it is still only 10% of the cost. I think people have lost sight of the fact that in 2020, not even now it's even, the feds are paying an even greater share, but in 2020, the state share will max at 10%. So economically, it seems like a really great deal. And for people that are concerned about the spending, I think we ought to look around at the other states that are using those federal dollars when we're not. And I think Kim will probably talk maybe about some of the economic impacts that Medicaid expansion has had on the state in only 2 years, which are significant. Medicaid expansion has generated a lot of new jobs and added a lot of money to the economy, and actually made clinics like Jill's, which are for low-income people, much more financially stable and much more able to help a lot more people with a lot more services like integrated behavioral health and things like that. So if you have questions, you can ask him now, or we can just go on to Jill and save them all for the end.
I think we know a lot about the insured population, but I'm real curious about the profile of the uninsured. You know, what those people, are they defiant? Are they just so needy they can't afford that over food,
Yeah.
housing, and that sort of thing? I mean, has anybody done a study and looked at the profile of those people?
Well, Jill might be able, because she knows they
Yeah,
have a
Jill
fair
would be
amount.
serving this.
But I will say one thing that you should, that happens in this state, and you may remember this, Bob, from when you worked at the insurance department, is something called the family glitch. So if you are, I don't know why people don't sign up for Medicaid if they're eligible. That's a different topic. But if you are not Medicaid eligible, but you may be eligible for premium subsidies and maybe even cost sharing reductions in exchange coverage, some people are unable to access that eligibility because one of the spouses has an offer of employer coverage. If there's an offer of employer coverage, even if the employer is contributing $0 to the family coverage, which can be very expensive, they are no longer eligible for premium tax credits and cost sharing reductions. And I do think that there's a fair number of people who get knocked out of that way. Plus, there are younger people who just feel like they don't want to spend any money on health insurance because, you know, the young invincibles. But I do think the family glitch causes significant amount of problems, especially in this state.
I agree with that. When I worked in Madison County, it cost $1,000 a month for my spouse and my child's premiums for health insurance. And we were with the county, so you know, it was just, you work to pay for your health insurance premium essentially. And I think that if you're not eligible for Medicaid because of that reason, and you can't afford those premiums, you go without. So I guess I'll segue into what I'm here to talk about. So, and I also want to say, one of my employees is here, and he is an expert in enrollment in Medicaid and could probably shed some light on your question as well. I think he helps people every day get signed up for Medicaid and would probably know. Do you have anything to add, Steve, as to why people don't choose to get on Medicaid if they're eligible?
No, but you and Christina
Hit it.
know us, but I see it.
Okay. So, Pureview is a community health center. We're here in Helena, and we also have sites up in Lincoln and also at the homeless shelter here in Helena, God's Love. We are one of 17 community health centers in Montana, and of those 17 community health centers, so there's 43 different sites. I think the important thing for this conversation to remember is that community health centers have an obligation to serve everyone, but really to serve those who are uninsured or who are underinsured. We have clinics in rural areas, so we're providing primary care, mental health, and dental services in lower, in areas where they don't have access to health care. So it's not that we just serve low income, it's anyone who faces barriers to receiving healthcare services. So that could be the community of Lincoln, which is 60 miles from any other healthcare services, and quite frankly would have to call an ambulance every time there is a problem if the clinic wasn't there, which costs the community a lot more money. Community health centers see about 10% of our state's population, so a little over 100,000 patients. And we have seen an amazing shift in our revenues since 2016 when Medicaid expansion was implemented. At Pureview alone, we've had 20% of our uninsured patients have gone to become insured patients. In the first year alone, that was $500,000 of care that we provided that would have otherwise been uncompensated. So we are required to provide comprehensive care, which means all of those services that I mentioned, primary care, dental, and mental health, to all of our patients. They get team-based care, which means they get a provider, they get a nurse, they get a diabetes educator, they get a case manager, they get a dentist, a hygienist, they get a mental health prescriber, they get therapists, licensed addiction counselors. All of those positions are part of our team-based care, which makes the visit a little bit more costly, but we also prevent a lot more emergency room visits, urgent care visits. We're all the community health centers in Montana are patient-centered medical homes, which means that we have to provide preventative services. We have to make sure that patients are being referred for specialty care, and we have to have arrangements with specialty care providers to take our sliding fee scale. So we have a lot of ancillary staff that are making all of these things happen to wrap services around our patients, regardless if they have insurance or not. And it does cost more money to provide those services, but they are incredibly important. I'm mostly concerned that if Medicaid expansion were to go away, that those 20% of patients who've now gone to become insured now are within a treatment plan with their provider. They have prescriptions and doctor's orders that they're following. And if they become uninsured, that becomes more and more uncompensated care that the community health centers have to pick up. So, I mean, all in all, it will only hurt us a great deal to lose Medicaid expansion, and we would really have to cut back on the services that we provide to not only the main community sites, but especially those rural clinics as well.
And those patients would probably lose access to a lot of their drugs.
Yeah. Yeah, I mean, and that, we have a pharmacy, so that becomes prescriptions that we have to cover at no cost if they can't afford them. So. I'm happy to take any questions as well, or I'll just pass it on to Kim.
Were there questions for Jill? No.
I would just share one thing, if I may. It's not a question. I work at Pureview, and since the Medicaid expansion, just the number of people that I have seen who, for one reason or another, had foregone any medical care for a decade or 2 decades. It's interesting because I am so appreciative to hear the big numbers right now. I see people one-on-one, and I lose sight of the largeness. But the individuals that I've seen over the last, 3 years since 3 years since the expansion, it's amazing to me, people that could not afford healthcare that now come in and are taking care of themselves and their families for the first time in maybe, like I said, decades. That's just a little personal snippet.
Especially for mental health and dental.
Yes.
We saw a big uptick in visits for those services.
Well, I think going backwards a little bit, expanding Medicaid in Montana was a difficult thing to accomplish. And I think we sometimes forget, Christina mentioned the Medicaid gap, which is actually the cliff in Montana. Our eligibility was so low, very, very low, that if you were below 100%, you really had no opportunity to get on Medicaid, and there was no way you could afford private insurance. But what you have to remember is the Affordable Care Act assumed that all states would expand to 138%, and 100 to 138% was meant to offer some opportunity to move to private insurance if people wanted to instead of Medicaid and could figure out a way to afford it. So when the Supreme Court made it optional for states in the summer of 2012, in the summer of 2012, it changed the political landscape like that. All of a sudden you had fights in states where states felt like they could make a stand against the ACA, right? And it left this incredible gap that wasn't meant to be there, and it was complicated, and it put a lot of working class and poor people in a really bad position. So the Human Rights Network, with a whole variety of entities, really started in earnest in the fall of 2012, trying to build a campaign to expand Medicaid. And you might recall that in 2013, we had a robust debate around Medicaid expansion in the state. A lot of education, a lot of personal testimonials, a lot of legislative advocacy, and that bill actually, a very imperfect bill, I will say, died on a 50-50 tie vote in the House, and then we had to wait. So there was an attempt at a ballot measure that, for a variety of reasons, didn't move forward, and we went back into the 2015 session a lot more prepared, honestly, to build a legislative solution that made sense. There was a deep and significant bipartisan compromise that would get people covered, that, you know, allowed some Republican legislators that really wanted people to pay into the system, right? That was very important. So Christina mentioned premiums and copays. There's a voluntary workforce readiness program. Essentially, it's called HelpLink. That was a compromise to avoid work requirements, which in 2015 would not have been approved by CMS, which is the Center for Medicaid and Medicare Services. So Christina also mentioned this is a waiver program. So you can expand Medicaid eligibility, income eligibility to 138%, and you're done. You know, people just roll into your Medicaid program. If you're making a compromise that is outside of Medicaid law, the standard Medicaid law, you have to go and ask. And there are waivers that are called demonstration waivers that are meant to look at different innovative ways to run a program, and that's what we have in the state. We have a waiver. So Ed Buttry, who is a Republican from Great Falls, was really committed to working on this. He worked with Democratic legislators and the Bullock administration to come up with a compromise that, you know, I think is deep, significant, and works. It works, and we know it works because there are 100,000 people on Medicaid right now, you know. Actually 96,000, it's projected to be 100 within a year. So what we know is that people pay premiums, and by and large, people on Medicaid, they pay them. You know, they're small premiums, but I know at the network right now, we have some canvassers working on I-185, and I'll get to I-185, I promise, that are on Medicaid themselves, and they're proud of paying their premiums, you know, and they actually can't understand how the legislature could take this away when they're paying their premiums, you know. It's significant to them, and I think that's important for us to remember when you're making $16,000 a year, you know, 2.5% or 3% of your annual income is significant, just like it is for us. So we have a really successful program right now. And I think what I-185 is about is extending that program. You know, I think a lot of the people that were involved in drafting I-185 were worried about changes at the federal level that would allow for things like work requirements, allow for things like way higher premiums for people that just can't afford that. Drug testing, things like that. And so the I-185 campaign is really about continuing a program that has been incredibly successful. You know, we have seen $36 million of savings to the state. And to answer your question, the program started January 1, 2016. So it's newer, we've gotten used to it, it's important. I feel like it's part of the fabric of our healthcare system in Montana already like that. But it's actually, it hasn't been around that long, you know? So since January 1st, 2016, we have seen $36 million in savings to the state. We've seen economic reports from the University of Montana and from Manat Health, which is a very fancy law firm that has a whole division that specializes in healthcare, did a report also that has seen an incredible economic impact. Both of those have said with job creation, 5,000 jobs, with increased income and the income tax that comes from that, and a decrease in uncompensated care, Medicaid expansion pays for itself. for sure. $100 million in decrease in uncompensated care is a big deal to our healthcare system. A big, big deal. And it's especially big for rural hospitals, critical access hospitals. That, you know, in Montana, we're a rural state, right? And these hospitals are critical to those communities surviving. And they were struggling. They were getting buried under uncompensated care, and Medicaid expansion was a lifeline. So we know that. This is good policy. You know, it's changed people's lives. We heard, you know, you can hear testimonials about the impact being able to go in and see a dentist, go in and see a doctor has had. We have more dramatic stories. People that couldn't get on a transplant list because you have to have insurance to be on a transplant list. Getting on a transplant list, like those are the dramatic stories, but they're like everyday stories of people being able to access care that they didn't have before. It's a big deal. So what I-185 does is it increases the state tobacco tax, all tobacco products, and it changes the definition of tobacco products to include e-cigarettes, vaping products, like that for the first time. They've never been taxed before in the state of Montana. So it's $2 on a pack of cigarettes, and it's a parallel increase on other tobacco products. Like the way we tax tobacco is a little complicated, but across tobacco products, you're gonna see a comparable increase to $2 a pack. That funds the state share of Medicaid expansion, which is 10%. It's $26 million a year. And it funds additionally some veteran services, some programs for veterans, the 2 veteran homes, and some suicide prevention services, some services, in-home services for people, seniors and people with disabilities so they can stay in their homes and communities, and then it funds some prevention programs for tobacco use to prevent people from starting smoking, specifically kids, and then some cessation programs to help smokers quit. That's what it funds. It's pretty simple. And then it lifts the sunset on the Medicaid expansion program. So what I should have said at the beginning of this, and I forgot to, but I'm going to say it now, is that when we passed the HELP Act in 2015, there was a sunset on that. And it is set to sunset in June of 2019. So the legislature meets, you know, January 3rd, 2019. And, you know, we're worried about a lot of things related to having a Medicaid expansion program that works. Like I do think that there are a whole set of Republicans in the state that really want people to be covered and they don't want to see Medicaid expansion go away, despite the fact they put a sunset on this policy, which was very frustrating to a lot of us that worked on it. But we're really worried about provisions being added that wouldn't let the program work for people. Right now we have 81% of enrollees, as of probably 4 months ago, are in families where someone works, right? And 63% of people work themselves. But the tricky thing about work requirements administratively is what work means, how many hours you need to work. And if you guys remember, do you remember TANF? So you had, TANF, which is Temporary Assistance for Needy Families. It was welfare reform. All of a sudden you had work requirements on a cash benefit where you were required to work 30 hours a week at below minimum wage, right? And that program just ended. It just kind of disappeared. You don't hear about TANF anymore because it didn't work for the people. And people, you know, poverty increased and people migrated into different programs and different situations. It no longer served its goal. It no longer met its goal, no longer served its purpose. And so I think that's the worry of people like me on work requirements is will this allow people to get access to healthcare, which is the whole point, right? And our whole system benefits when people can get access to healthcare. And then drug testing and other provisions like that that really keep people who need it off the program unnecessarily and with a huge administrative burden to the state, I might add. Like the costs really increase administratively. So I-185 is actually very simple. I explained it, I think, in about a minute. There's nothing else there, you know. But what we've seen is big tobacco companies come in and spend a lot of money trying to distort what the initiative is, which makes sense. People will quit smoking. Kids won't start smoking. It's gonna cut into their profits. So it's no surprise that they're spending big, you know, and I think our charge on I-185 is making sure that we're telling our family, our friends, our neighbors, that it really is this simple, you know, and you can point to editorial opinions in papers across the state, you can point to really credible sources like David Ewer, a former budget director, to say, actually, this is funded. Actually, this does exactly what proponents are saying it does. And it's really important to vote yes, because 100,000 people are counting on us to get out and vote yes. And with that, before I end, Ella Smith and Garrett Langford are right over here. And they are incredible folks from Montana Women Vote and the Montana Human Rights Network running a volunteer program. So if you're interested in helping out and pitching in, there's lots of ways you can do it. If you talk to Ella or Garrett, you can get involved, talk to your neighbors, or talk to strangers. I talk to a lot of strangers about I-185, and make sure that we finish strong and make sure that we don't let big tobacco buy this, you know, which is a real concern. They cleared $12.4 million in spending this reporting period, and I think they're on pace to get close to 16 or 18 million. I don't think Montana's like that, and I think we have to get out and talk about what's actually at stake with I-185.
More questions?
I just had a question for you.
Yeah.
God willing that it passes, but that if it's successful and fewer people smoke, how does the money keep coming if the money's been funded by?
It's a really good question. So the budget office that does the fiscal note actually uses a model. So we know a certain number of people will quit, right? Like over about $1.50 a pack changes behavior, and we know that. And that's the reason that a bunch of public health advocates, in addition to Medicaid expansion, that's the reason that the Heart Association, the Lung Association, American Cancer Society are all supporting this. But not everyone will quit, and starting to tax vaping products will be an increase in revenue. And so they model out, you know, how people will quit, what that will look like for revenue. They also model black market sales and also people crossing state lines.
Right.
And they, by 2020, they project $74 million in revenue, you know, and so you can actually go in and look at this very nerdy, complicated fiscal note and see all of the models they use, but they consider all of that. You know, at some point down the road, we may have to look at other funding sources, but it's not in the near term.
I look at these horrendous ads and I don't see anybody answering the question, is the mandate unconstitutional? Is it illegal, the mandate? That's the argument, that nobody shot Durham on TV yet.
Well,
So we don't, yeah, so the charge, I think the charge is this an appropriation? We don't think so, they think so, and, you know, if they decide to challenge it, a court will have to decide, you know?
the Supreme Court.
Yeah.
And so other attorneys making comments about the constitutionality, I mean, there's nothing more than their opinion. And the ones who will decide if someone wants to bring it to them is the Montana Supreme Court. And the unfunded mandate allegation, I think, is just a complete red herring.
Yeah, that's not true.
There's nothing out there that even looks like that. The constitutionality, at least the way Kim has talked to me about it, it's related to whether or not,
It's an appropriation.
yeah,
We don't.
because it removes the sunset.
Yeah, yeah.
So,
But it's not, I mean, it's not an unfunded mandate
no.
in any way that you would define unfunded mandate. It raises enough money to pay for the programs. And in fact, raises a little bit more than what's necessary. You know, it looks like it'll continue to raise a little bit more than necessary even in the out years. And the bottom line is the legislature always has the ability to come in and adjust eligibility. So the idea that it's either unfunded or a mandate is made up. It's a lie.
I have a second question.
Yep.
15, it seemed to me it required some backroom work just to get a hearing on it, to get it to the floor for a vote. And then one vote passed it. How are we going to beat that this year, next year? Or are the odds against it? Is that block stronger than it was in 15?
Yeah, so I think you have really dedicated people on both sides of the aisle, and certainly with the Bullock administration, and it's not going to be easy. Nothing about Medicaid expansion has been easy in Montana, or really anywhere, other than the sort of super blue states since 2012. But I do think that there are people that represent various districts in the state that really care about their critical access hospital, that really care about their constituents, and they have ideological differences with me, Governor Bullock. But they want the program to continue. And, the bottom line is we need to keep the lines of communication open and make sure that we're not forgetting what the goal is, which is to maintain coverage for 100,000 people. If I-185 passes, and I think and hope it will, all the legislature needs to do is appropriate that money. It'll sit in a special revenue account, we just need to appropriate it. If it doesn't pass, things get a lot more complicated.
Then what? If it doesn't pass what?
Things get a lot more complicated
Right.
in
And
terms
then
of
I
policy
was
provisions.
just wondering about that because I talked to somebody this week and I was supporting I-185 and he said, now is that to help people quit smoking? And I said, well, yes, but it's also to help raise money for the Medicaid expansion. He said, well, I'm opposed to that. I said, what do you mean? He said, why doesn't our government simply do that? Why punish people who smoke for doing something they ought to do anyway? Not smoke, but pay for the Medicaid expansion. So his argument was a funny one to me, but the state ought to do this anyway. So why punish people who have a sin tax placed on them rather than simply being responsible for who we are? I thought it was an interesting argument, and I thought the legislature simply ought to say, are we going to do this or not?
Yeah. Well, I have a lot of ideas for funding the state share of Medicaid expansion, but this is what we've come up with. It's a progressive health policy. People will quit smoking, kids won't start smoking. It actually is, we are taxing a specific population, but we're taxing a population that costs the healthcare system a lot.
Yeah.
$440 million a
Costs a
year
lot, right?
in costs associated with tobacco-related illness. And that is an incredible amount.
Yeah, and the state passed a tobacco tax earlier to fund CHIP and some other healthcare programs on exactly those grounds because of the costs of what smokers contribute to the healthcare system. And that didn't seem to raise nearly so many. Kim understands better why this one seems so much more controversial, but.
Well, so tobacco companies didn't care as much in 2005. They were doing fine. The context around them and their profits has shifted. And for the last probably 6 or even 8 years, they have been spending considerably against initiatives like this and state legislative proposals. But to get back to your point, the state of Montana needs to fund the state share. It's $26 million a year. We need to fund it somehow, and we haven't raised the tobacco tax in the state of Montana since 2005, January 2005. There was an initiative that passed in 2004. It's been a long time. it's the right thing to do in terms of public health policy. And the funding goes to incredibly important programs. So I think people are gonna have to decide, right? Like, if they like what it funds, but they don't like the revenue source, that's a decision for individual voters to make. I think I-185 as a package is an incredibly progressive health policy. You know, it will get people to quit smoking, it will prevent, I mean, it's shocking to me how many, I think it's gonna prevent 8,000 kids from starting to smoke, which is incredible. And we've seen big tobacco shift their focus almost entirely on youth. Like their marketing is really kind of disgusting, you know? Yeah, especially vaping. And they know they're gonna have lifelong customers.
That's their future market.
Right, exactly. And so I just think it's an incredibly progressive thing for the state of Montana to do, to sort of protect youth from a lifetime of a very powerful addiction that has really negative health consequences for individuals, but also just incredibly costly to our healthcare system. But I do think that each voter is going to have to decide on the components.
Well, but I think that for people who don't like the tobacco tax aspect of it, they need to maybe just consider the bottom line, which is if they don't vote for it, it's very likely that we could lose expansion and 100,000 people will lose coverage. And I really believe because we did an economic report, BBBR did one in 2012 that we commissioned about the economic impact that Medicaid expansion would have on Montana, and that was carried out completely by this later one that was done in 2018. So it's consistent throughout. I think it's like a patchwork quilt effect, and this is the thing that bothers me the most about what happened with that Supreme Court decision and the Affordable Care Act. We're now looking at a patchwork quilt of coverage. And so people in Montana, if we lose expansion and they lose, you know, coverage opportunities, you know, jobs and people, and I mean, they'll move. I mean, neighbors all around us, including North Dakota, have expanded Medicaid. Obviously Washington, I mean, 34 other states, many in the West. And it's a matter of, I wouldn't want to live here without those opportunities if I was lower income. And it's very bad for the economy, if nothing else. For people that don't care about health care or access to health care, it's very bad for the economy.
Yeah, and it has a ripple effect across the insurance industry too.
And it has a ripple effect across the insurance industry, which, you know, we're trying to stabilize. And this will make it even harder to do that, so.
And it's hard, the most direct thing is that, you know, our neighbors will lose health insurance for themselves and family members. But, you know, I said earlier, $100 million in reduction in uncompensated care.
Yeah.
Everyone that's in an insurance pool, everyone who's insured privately ends up paying for that.
Yeah.
If it comes back,
care.
you know, like there's a bigger impact even.
Mm-hmm.
I mean, I care the most directly about, you know, my neighbors and their ability to access care, but system-wide, it would be devastating. So.
Have there been initiatives in the past that include appropriations? And if so, what do the legislature do?
Yeah, so the best sort of parallel is the Healthy Montana Kids Initiative from 2008. Similar in structure, created a special, so increased eligibility in both children's Medicaid and CHIP. Did some other cool policy things that aren't as relevant to this conversation, but created a special revenue account and took a percentage of the insurance premium tax and diverted it into that special revenue account to pay for it. And then the legislature had to go in and appropriate it. And it's important to note that that was a huge fight to get them to appropriate that money. And they did tweak it and sort of nip around the edges and change it a little bit, but in the end they did appropriate it. And then the 2004 tobacco tax initiative did a similar thing where it increased the tax, raised revenue, and then funneled the money into sub-accounts to pay.
Specific programs designated
Yeah, and so they're called state special revenue accounts, and the money just sits there until the legislature does something. You know, so they need to move the money. If they want to, you know, ignore the will of the voters, they move the money into something else, or they appropriate the money as it was intended.
It was very similar.
Yeah.
In fact, this ballot initiative amends statutes that were created as
Yes.
part of that ballot
Yeah,
initiative.
that's right.
So it's not like an untested vehicle that has any kind of proven track record of unconstitutionality.
Right.
And Bob,
Have
did you?
any initial polls been done on the general sentiment about this initiative?
Many polls.
Yeah, I mean, I think it's generally a very popular idea. I think anytime you have this amount of spending, voters get moved around naturally, right? They're hearing, oh, it's an unfunded mandate, is it this, does it actually fund what it says it's gonna do? So I think there's support for it. Our proactive campaign effort needs to execute, you know, down the stretch. We're about 30 days out. And we need to make sure that we're talking to people, that they understand the components of it, they understand what it does, and that they know that what they're hearing over the airwaves from big tobacco are lies. You know, they really are. And that's tough. You know, it's tough to call someone a liar, but it's easier to call big tobacco a liar than other entities.
They have a track record of lying.
It's not hard at all.
Yeah. There's one more thing, because I know we're out of time, but to sort of bolster the things that Jill was saying about what Medicaid expansion has done for their clinic and their ability to offer more services. I heard a similar thing today. I happened to be at a tribal consultation about the individual market and some issues related there, where all the tribes were reporting on their increased ability to offer services to tribal members as a result of Medicaid expansion. IHS and the clinics that the tribes run or IHS runs is now getting compensated for the care that they're providing, and that has allowed them, for the first time ever, I can't explain it all in a couple minutes because it's complicated, but for the first time ever, many American Indians in the state have gotten access to knee replacements, colonoscopies, other types of care, dental care, that simply was never paid for. People think that Indians get all this free health care from IHS. They don't, because every year they run out of money. And this program has allowed them to fund those services and provide so many. It was remarkable in the space of just a couple of years how much they've been able to improve services. And American Indians are 7% of our population, and by and large our tribes are not rich.
But are they registered to vote?
Yeah.
Many of them are.
Yeah.
But I think it's another important. I was really excited to hear about that report back.
It's cool.
And I wanted to say, we see on average about 400 veterans, and 20% of them are on Medicaid. So they do need Medicaid as well. Paul?
Can I make it? Two quick comments. One about funding. The 04 thing, when they raised the price of tobacco, knocked the easy, low-hanging fruit off the smoking rolls. So there was a drop in smokers. Those are the people that wanted to quit anyway. Okay. The people that are left are the people that say, hell no, I'm never gonna quit. And so I doubt that another $1.52 is gonna change that population much. What I do think it's gonna do though, the education program for prevention for kids getting on cigarettes, that's where we're gonna see the impact down the road. So I don't think there's gonna be as much of a hit to the tax.
90% of smokers start before they're 18. They can impact that.
That's right.
That's
why this is huge.
Yeah.
The second thing I want to say is on the 18th, it's going to be a starry, snowless night in Helena. We're having another public forum about the same issue at DPHHS Auditorium. Y'all should have a flyer. We've got a couple of participants in the audience today, and we'll pick up with John Modell, who helped draft this, who will talk a little bit about constitutionality and all that kind of stuff, and the mandate issues, as well as the numbers that we've received here tonight. So I encourage everybody to circle the 18th on your calendar.
Did someone in the back have?
Well, if it passes, what's the time, what needs to be done between passage date and June 19th, when the current program closes?
Jim has to work really hard.
The legislature wouldn't even do a rental car tax.
Yeah,
in
so
special session.
if this passes, the tax goes into effect, I believe it's January 1. There are different effective dates. So the increase will go into effect, the revenue will start flowing into the state special revenue accounts. And the legislature needs to appropriate them during the session.
No loopholes.
No, there's no loopholes. I mean, it's a pretty straightforward task for me and my colleagues. And, I think that there'll be some robust sort of debates and conversations, but that's what we have to do. If it passes, the tax goes into effect, the money starts rolling into the revenue account, and what we need to do is appropriate it. So.
Okay, well, yeah, maybe, I do like to try and stick to time. Maybe we'll take just one more question.
Just very briefly, Kim, an explanation or a description of the VA programs that this money would
Yeah, so it funds it sends some funding to the veterans' homes, of which there are 2 in the state of Montana, and then it funds a suicide prevention program.
And is there a separate suicide prevention for the general population, or is it specific to veterans?
So this is specific to veteran suicide prevention. What I'm not sure about, and I need to look into because it came up on the doors last week, is whether we're funding an existing program or whether we're starting something new, and I'm not actually sure about that.
Thank you.
Yes.
Good. Okay. Let's say thank you.